Good morning, everyone. So I'll be speaking on hepatic ciliopathies. So this will be the overview of my talk. What are the abnormalities of cilia, and syndromic and non-syndromic presentations. So some of this part will be mostly actually genetic syndromes, and then hepatic ciliopathies. What is the presentation and management, particularly focusing on congenital hepatic fibrosis and CHF. I will not be focusing on the renal part of it. So cilia are cellular organelles with an antenna-like structure. So the cilia are presented almost all the cell types, and the number of cilia may vary from 1 to 200 to 300 cilia per cell, and they develop from the centrosome during the process of mitosis. And there are two types of cilia, so motile and immotile cilia. Immotile cilia are in the form of groups on the cell surface, and they are capable of beating in a constant frequency to generate a fluid flow. I will give the examples. So immotile cilia are the primary cilia. So they are present one per cell, and they are immotile and involved in the communication of the cell with its surroundings. So this is the basic structure of the cilia. So we can see here, so in the lower part there is the basal body, then the transition zone. So the transition zone is connected with the transition fibers. So then this is the ciliary structure with ciliary membrane, and inside the cilia are flagella. And to differentiate from the motile and the immotile cilia, so motile cilia have 9 plus 2 structure of the flagellae, and immotile cilia have 9 plus 0 structure. So inside the cilium, the flagella have the various the proteins like outer dynein, inner dynein, then nexin link and a radial spoke. So nexin link and radial spoke are not there in the immotile cilia. About the transition zone functions as a gate which and regulates the entry and exit of proteins into and outside of the cilium. And there is a protein complex which is called BB-zome, which is abnormal in a syndrome which is called Bardet-Biedl syndrome. So this protein complex have vesicles with membrane proteins, and which is responsible for the integration of the membrane proteins into the ciliary membrane. So the vesicle delivery to the cilium happens through various receptors and signaling proteins, and proteins are transported from base to the tip and then back over the axonal microtubules, and this complex is called the interflagellar transport protein complex. And there is another thing which is called IFT motor complex. So again, coming to the differences between motile and immotile cilia, as I already said that motile cilia generate the fluid flow, and they are found in few tissues only. The typical examples are tracheal epithelial cells for the movement of the mucus, fallopian tubes for the movement of a fertilized ovum, and the sperm cells and nodal cells have single cilia. So sperm cells is for the movement, and the nodal cells are responsible for the left and right symmetry. Then immotile cilia, so they are responsible for the communication between the cells and are present in almost all the cell types. They act as a sensory signaling hub of the cell and responsible for various tissue processes like embryonic development, tissue morphogenesis, homeostasis by regulating the WNT and the hedgehog pathways. And they are also responsible to initiate or regulate the signaling by sensing their environment and ensuring delivery and or removal of the signaling proteins to or from the cilium. So various ciliopathies have can involve different organs, almost every organ of the body. So they may be renal cystic disease, blindness because of retinal involvement, neural tube defects, intellectual disabilities, skeletal abnormalities in the form of polydactyly, short limbs, or even chondrodysplasia, ectodermal defects, obesity, situs inversus, infertility, respiratory abnormalities, and some of these are part of various syndromes. So depending on where the mutation is there, whether it is related to the localized to the basal body or to the transition zone or to the axoneme, different syndromes are there. So this is actually the chart of, I think it may not be very clear, but the ciliopathies are differentiated on the basis of the different organ systems involvement, whether there are neurodevelopmental ciliopathies or ciliopathies with major skeletal involvement, or it may be part of obesity or renal ciliopathies or primary ciliary dyskinesia like Cartagener's syndrome. So then coming to the two common ones and which are related to the hepatic ciliopathies, congenital hepatic fibrosis. So these two common syndromes we should remember, Joubert syndrome and Meckel-Graber syndrome. So Joubert syndrome is associated with cerebellar involvement in the form of hypotonia, ataxia, developmental delay, cerebellar and brainstem malformations, and the typical sign on MRI, which is molar tooth sign. I will show the picture later. And then other abnormalities in the form of renal cysts, congenital hepatic fibrosis, polydactyly, coloboma, retinal dystrophy, oral frenula, respiratory abnormalities in the form of tachypnea or apnea, and morbidity in Joubert syndrome is primarily related to renal and hepatic disease. And the prevalence is around 1 is to 80,000 to 1 lakh. Then Meckel-Gruber syndrome. So this syndrome is due to mutations in different gene from Joubert, but the phenotype is almost similar, overlapping phenotype, but it is more severe and is lethal perinatally. And this is characterized and diagnosed by presence of 2 of the 4 features in the form of occipital and cephalocele, polycystic kidneys, polydactyly, and congenital hepatic fibrosis. And in the presence of 1 of the feature, there should be 2 other anomalies in the form of cleft lip palate, cardiac septal defects, hollow prosencephaly, agenesis of corpus callosum, Dandy-Walker malformation, microphthalmia, situs inversus, ambiguous genitalia, and shortening or bowing of long bones. And the prevalence is less, is around 1 is to 1.4 lakh. So these are some of the pictures. In the first picture, so this is interesting, the panel A, where we can see a typical molar tooth sign. So this is like a molar tooth. So here there is more deepened interpeduncular fossa and elongated cerebellar peduncles, so giving a typical molar tooth sign to the midbrain. Then other pictures are showing polydactyly in an unborn fetus, skeletal abnormalities, and here also in the panel B we can see occipital and cephalocele. Then other pictures are showing again skeletal abnormalities, thoracic dysplasia as in June asphyxiating dystrophy, obesity with short limbs and short stubby limbs. And also there are certain, like this picture is showing enamel defects. So various syndromes, just to name a few, are Elstrom syndrome, Bardet-Biedl syndrome, June asphyxiating thoracic dystrophy, Ellis-Van Creveld syndrome, Joubert, Meckel-Gruber, senior local syndrome, and Simpson-Golabi-Behmel syndrome. So coming to hepatic ciliopathies. So this is one of the first paper which came in 2006, where the isolation of the primary cholangiocyte cilia was shown, and these are the electron microscopy pictures. So just to compare from the portal vein and hepatic artery, so there are no cilia in these 2 structures, but in the bile ducts, this is the large bile duct and this is the small bile duct, so there are cilia. So in the cholangiocytes there is 1 cilia per cell, and the length of the cilia is related to the diameter of the bile duct. So larger ducts, they have longer cilia. So, and also there are certain markers like acetylated tubulin was used as a ciliary marker, whereas P2Y2 was used as a non-ciliary cell membrane marker. Then function of the cholangiocyte cilia was explained in this paper from Gastroenterology 2006, whereas it was mentioned that cholangiocyte cilia are sensory organelles containing polycystin 1 protein, which is a mechanoreceptor, and polycystin 2 protein, which is a calcium channel, and another protein which is calcium inhibitable adenylyl cyclase isoform 6, which is AC6, and through which luminal fluid flow affects both calcium and the cyclic AMP signaling in the cell. So basically what happens in the cholangiocyte cilia, so the cholangiocyte cilia acts as a mechanoreceptor as well as an osmoreceptor. The cilium bends under the influence of the biliary luminal flow and increases the intracellular calcium and decreases cyclic AMP. And the complex of the polycystin 1 and polycystin 2 forms a functional complex within the cilia, and PC1 senses the bending and relays the information to PC2, which acts as a transmembrane calcium channel. So so basically when the cilium functions, there is increase in the calcium and decrease in the cyclic AMP. And if there is abnormality of the cilia, there is decrease in the intracellular calcium and increase in cyclic AMP. So what happens with the abnormalities of the cholangiocyte cilia? So so mainly the defects which are mentioned are related to the ductal plate malformation. So I will come to the ductal plate malformation. So this is actually the developmental part of the bile ducts, how the ductal plate is formed. So this is in a rat model from day 12 to day 18 to perinatal. So initially the hepatocyte layer around the portal vein is is unilayered, like here shown in the green. Then it becomes bilayered, and within this bilayered hepatocytes, the ducts are formed around the portal vein. So the initially the ducts, this lumen is around the portal, around whole of the portal vein, and then a part of a major part of this the ductular lumen gets involuted, so that only one or two ductular structures are remained at the time of the birth in the rat model. Again shown here in the portal vein, around the portal vein, so there is a lumen ductal plate which and intervening parts get involuted, ultimately leading to a normal ductular structure in the portal tract. But when these structures remain, these lead to the formation of ductal plate malformation. Again in this cartoon, showing the same thing, the lumen and then small ductules or a very large ductular structure or ectatic ducts. Ultimately, in the transverse section, we can see here that around the portal vein there will be multiple ducts, or this is a typical central dot sign which is seen in Carolese. The portal vein becomes more prominent, and around the portal vein there is a cystically dilated structure, and this is the appearance of a typical ectatic ducts around the portal vein. So this is the picture on the CT, dilated ducts, and in the center we can see a dot of portal vein. So ductal plate malformations are classified as whether they may be ectatic or there may be problems with the involution. So ectasia ones are Carolese disease, and this is usually associated with ARPKD, autosomal dominant polycystic kidney disease, or polycystic liver disease. Then with involution, these are congenital hepatic fibrosis or von Weinberg complexes, also known as biliary hematomas. And when there is a combination of Carolese disease and congenital hepatic fibrosis, that is called Carolese syndrome. So morphologically, they are classified as whether there is involvement of small interlobular ducts, medium-sized, large-sized, or larger extrahepatic ducts, shown in this diagram. Smaller ducts, biliary hematomas or von Weinberg complexes and congenital hepatic fibrosis. Medium-sized ducts, so this is adult polycystic liver disease. Then large ducts, Carolese disease, and extrahepatic large ducts. The large extrahepatic ducts, they are leading to formation of choledochal cyst. So coming back to the ciliopathies and congenital hepatic fibrosis. So as we can see here, autosomal recessive polycystic kidney disease, dominant disease, Meckel-Gruber, Bardet-Biedl, June syndrome, Coast syndrome, Joubert syndrome, or Ellis-Van Creveld syndrome, Ivermark syndrome, Elstrom syndrome, Senior-Loken syndrome, Mainzer-Saldana syndrome. So most of these syndromes have liver or kidney involvement. Liver involvement is in majority in the form of congenital hepatic fibrosis, but there is extra hepatic and extra renal involvement also, multi-system involvement in the form of retina, mental retardation, cerebellar or cerebral involvement, cardiac, lung, pancreas, polydactyly, sterility, or situs inversus. So the prevalence of these all range from 1:20,000 to 1:1.4 lakh. So as I already mentioned, so it is imperative to look for the retina, MRI, echo, and the complete skeletal examination to look for these syndromes. So presentation of congenital hepatic fibrosis, mostly it is portal hypertensive from 90 to 100%. Cholangitic presentation is around 30 to 40%. But when cholangitis is there is associated portal hypertension also. So these are some of the pictures, like broad band of fibrosis in congenital hepatic fibrosis along with ductular structures in the form of ductal plate malformation. Again, some of the pictures showing cholestasis due to cholangitis and with broad bands of fibrosis and ductal plate malformation. So again, this is a 6-year-old child from one of our patient, broad band of fibrosis with abnormally ectatic dilated ducts, and there are nodules also. So this was a 6-year-old boy who already developed almost a picture similar to cirrhosis. So coming to studies from literature, so this is an older study from PGI Chandigarh where 15 patients, and this is a study from Birmingham, 40 patients. So median age at presentation was 8 years from the Indian study, but from the UK, so they presented early, around 2.0 to 2.5 years. Clinical presentation from the Indian study was GI bleed 40%, cholangitis 20%, and hepatomegaly 100%. Portal hypertension was almost presented in all of them. Liver functions were normal. From the UK study, it is important to understand that with early presentation in infancy, So they have presentation more with renal involvement in the form of oligohydramnios, pulmonary hypoplasia, renal disease, hydrops, echogenic kidneys, hypertension, and chronic kidney disease. And 80% of these had Caroli syndrome. Whereas the later group, older children, infantile or childhood presentation had organomegaly, GI bleed, and hypertension was was very less often. Portal hypertension, although was present in 86% of the patients, and in this study from UK, almost half of the patients required liver transplant, and 18 of these required simultaneous liver and kidney transplant. Sorry. Again, this is the largest compilation of 1,200 patients, both children as well as adults, of congenital hepatic fibrosis and Caroli's disease or syndrome. Median age at diagnosis was around 2 years, while the mean age was around 11 years, with almost equal male to female ratio. Isolated CHF was in around 10%, and ARPKD was the commonest presentation, 64%, and followed by Caroli's disease or syndrome in around 1/4 of the patients. An important thing to note here is hepatobiliary malignancy was present in 21. 19 of them were cholangiocarcinoma, and the median age at diagnosis of cholangiocarcinoma was 70 years. So the hepatic and the renal phenotypes of these diseases, so they do not correlate with each other. They may actually go in opposite direction, and they advance at independent rates, but both of them influence the prognosis. So these are some of the pictures. Like we can see here that in congenital hepatic fibrosis, the liver margins are smooth, but it is not always necessary. Some of the time we may see irregular liver and ascites, almost a picture similar to CHF. There may be atrophy, hypertrophic complex, and left lobe hypertrophy or even caudate lobe hypertrophy. So typical Caroli sign is seen because of portal radical enhancement, which is surrounded by the ectatic bile ducts. So this is one of the picture of our patient, the typical Caroli central dot sign. CT films of the kidneys showing lobulated kidneys with cysts. And this is a typical von Weinberg complexes with multiple cysts scattered throughout the liver, multiple tiny cysts. So shown here in the lower panel, biliary hematomas, so which are most often incidentally detected on a MRI scan. So they may even be missed on ultrasound. So they are usually asymptomatic, 0.1 to 0.3 centimeter in size, localized close to the portal tracts, and they are very rarely associated with portal hypertension. So they may even just be missed. Whereas on the other hand, the another spectrum is autosomal dominant polycystic liver disease, which is diagnosed when more than 20 round or smooth cysts are there in the liver, which are non-communicating, and their development is related to the hormonal feature. Like they are more common in females than males, and they're related to certain genes like SEC63 and PRKCSH. And they may be asymptomatic with abdominal mass, pain, or with cystic infection, bleeding, or with biliary obstruction due to the large cyst. And diagnosis is based on ultrasound, MRCP, and they can be treated like with somatostatin analogs like long-acting octreotide or lanreotide to decrease the size of the cyst. So this is congenital hepatic fibrosis. We should differentiate from other causes of non-cirrhotic portal hypertension like EHPV and non-cirrhotic portal fibrosis, depending on the age of presentation, firm to hard liver, and on biopsy, which shows thick fibrous bands surrounded by normal looking hepatocytes. So CHF constitutes around 3 to 12% of pediatric portal hypertension as per data from West, around 12%, from India around 3%. From our series in bleeders, around 135 bleeders, CHF constituted around 3.5% of overall bleeders. 5 of the patients presented with bleed. So this is our protocol, the departmental protocol. How do we approach children with portal hypertension, and how do we diagnose congenital hepatic fibrosis? Patients presenting with hepatomegaly or with variceal bleed or with splenomegaly or thrombocytopenia, we look for evidence of CLD. Label as either cirrhotic or non-cirrhotic portal hypertension. Then on based of Doppler, if there is cavernoma, then it is EHPVO, and if there is no cavernoma, then the patient may be either congenital hepatic fibrosis or CHF. The ultimate diagnosis will be biopsy based. So just few points on management. So there is no specific management for congenital hepatic fibrosis. Main thing is to manage portal hypertension, varicella eradication. Cholangitis is managed by aggressive antibiotics, and some of the patients may require those who present with biliary stasis or intrahepatic lithiasis, they may require ERCP or drainage by intervention radiology. And endoscopic sphincterotomy may be required for stone extraction. Partial hepatectomy may be indicated for segmental Carolese. And again, the ESWL or intraductal electrohydraulic lithotripsy may also be required sometimes for stone removal. So there is some data on TIPS in CHF. So around total 12 cases reported from literature. This is a study on 5 children. 4 had autosomal recessive polycystic kidney disease. And in 3 of these patients, this TIPS served as a bridge to liver transplantation, which was done around within 4 days in one of the child. In 2 years, after 2 years of TIPS in another child where there was TIPS stenosis, cholangitis, and end-stage renal disease, and ultimately simultaneous liver kidney transplant was done. And in the third one, the transplant was done 15 years later when the patient presented with cholangitis. So ultimately liver transplant was done. So about the data on transplant, so there may be different indications as shown here. If there is end-stage renal disease with portal hypertension, then simultaneous liver kidney transplantation. If renal disease with cholangitis, again simultaneous liver kidney transplantation. But if renal disease is alone, these patients may require isolated kidney transplant. If there is recurrent cholangitis or decompensated liver disease, so then isolated liver transplant. So this is the data. ARPKD mostly require renal transplant, whereas Caroli syndrome mostly requires isolated liver transplant. About cholangiocarcinoma, so it is seen in congenital hepatic fibrosis. They may be seen in younger age group, around 40 to 60 years as shown here. And while in Caroli's disease and syndrome, the cholangiocarcinoma is seen around between 60 to 80 years of age. So this is our data. So this data is not very refined. So these are 18 patients, 5 of Caroli's syndrome. There was portal hypertension in all of them. Varicose bleed was in 8. Cholangitis was there in 5 patients, and there was incidental organomegaly in 4 patients. And one of the child presented with neonatal cholestasis, and there was decompensation in 2 of the patients with congenital hepatic fibrosis. So to summarize, ciliopathies have multi-system involvement. The morbidity is related mainly to hepatic and renal disease, and the management is related to portal hypertension, cholangitis, or like in polycystic liver disease, it is related to symptomatic large cyst, and also to the renal disease. Thank you.